Okay guys, welcome back to our next YouTube clip for lecture 4, and here we will be specifically discussing the basic guidelines for strength training intervention. This is just to get you guys to think a little bit about how we would use the functional movement screen to create an intervention. Again, you do this more in depth next year as biokineticists, but for those who are not going to be biokineticists or moving further, I still refer you to reading material and areas where you can understand the concept and then start a team-based approach when you are working in the field as a coach or as a sports scientist. You understand the basic concepts behind it and the need to refer, and also the need to form a network. As a professional, you'll be working with dietitians, you'll be working with biokineticists, you're working with physiotherapists, and you'll be working with coaches, or you'll be working with physical education specialists or teachers or parents and so forth. Okay, so also discuss the most common injuries in youth in terms of their musculoskeletal system, becoming more biomechanics and biokinetics related, but as a sports and conditioning coach for youth athletes or as a sports scientist, you need to understand that if your training loads and volumes and so forth are incorrect, you are going to cause these injuries. And then of course the biokineticist and physiotherapists and parents are going to be knocking at your door, asking for the reasons behind the increased injury profile. Okay, so those are the two concepts we're going to cover now. So let's quickly have a look. Again, just in general, you conduct an analysis on a 12-year-old female athlete and notice that her overhead squat position consists of toeing out and medial deviation of the knee. Her arm and torso alignment are good, and there was no medial or lateral deviation of her hips. So let's just have a look at that type of picture, actually in the presentation I sent you. So for example, this youth athlete, she has medial deviation, her ankles are collapsing. In this picture, the guy's ankles are not collapsing, and her body alignment is poor. So let's have a look. There, medial deviation or collapsing or toeing out, and then upper body trunk is okay, but knees are moving medially. So again, coming to your actual more clinical application to the squatting position. Those of you who are still wondering why you would do this assessment before you provide a person with training for their squat or their lunge or their overhead squat and add plyometrics to that and add weights to that, hopefully by now you understand the reason. So those of you who have put this together, please be reminded that you must, if you state where a muscle is, you must be able to identify it as well. So don't just learn this parrot fashion. Make sure now the anatomy you've learned in the last 3 years with Dr. Bart, although not every year, nonetheless you should know this anatomy quite well. Okay. Let's just check here. However, the movements described are typically of a developing child or adolescent with poor perceptual motor ability due to either zero strength training years, only focusing on sport, and not balance training. Okay, so in our next section we're going to be learning about training years and how important it is to start early with interventions, and how important it is to do motor learning training early. So in other words, you should be teaching good squat technique from the age of 6. You should be teaching good squat technique from the age lunge techniques from the age of 6. You should be teaching good push-up technique. You should be teaching basic functional movements from the age of 6 years old, even 5. Although 5, cognitively the child might not be as ready. There'd be more free play activities, but yeah, around about 6-7 years old you should start, because this will increase your youth athletes training years but also decrease their motor learning, which is incorrect. So let's say these are the reasons why this athlete has these problems. So tight muscles, possibly soleus, lateral gastrocnemius, bicep femoris, and tensor fasciae lata, and that can cause that medial deviation of the knee. So when you're working with youth athletes or an athlete in general, or a normal client, it is important to know where these muscles are, and where this fascia is, and how you can use a foam roller to release them. But then of course you also need to activate muscles correctly once you've done it. So in terms of the rehabilitative process for this individual, stretching each muscle group can facilitate, but this may only lengthen the muscle itself and not necessarily the fascia surrounding the muscle. So go read up on the difference between what fascia is and how foam rolling compares to general stretching, and how mobility compares to stretching. So make sure that you remember what we did in class together when we did mobility activities together, and how mobility compares to flexibility training and how flexibility compares to fascia release training. So a combination of foam rolling could suffice. Okay, then those muscles that are in need of strengthening would be the medial gastrocnemius. Once you have foam rolled and stretched, these areas will need to be strengthened. The medial hamstrings, gluteus medius and gluteus maximus. So again, those of you who have not quite understood anatomy in a functional way yet, it is important to know how to strengthen these specific muscle groups in a isolated but also compound position way. So again, within the scope of this module, I'm not going to go into too much detail with you in terms of the assessment, but I just want you to be aware of it. So what I will do though is I'll refer you to the books that we've covered, some of them in depth in our biokinetics here, but that is where we do joint range of motion assessments, and then we'll also do joint muscle strengthening to identify and improve muscle deviations in a patient. So again, not within the scope of motor development, but what I'd like you to know for your prac exam is just in general what it is you need to do, and then of course you must know your anatomy, because by now you should know your anatomy. Okay, remember the above in brief. As I've said, there's a lot more rehab that goes into it, and that's of course without getting too much into depth and out of the scope of this module. Amanda is 9 years old. She's experiencing heel pain which persists during her gymnastics session and when she skips or runs at school. As you are one of her movement specialists, she is in contact that you are in contact with. Her dad wants to know what is the possible cause. Explain the possible reasons by discussing Amanda's physical activity regime and skeletal growth. Okay, so a common problem that we experience in children, and also something to consider when you're working with children in terms of the intensity and high loads and lack of strength and conditioning training that we do with children. We normally just focus on the sport and not enough on the strength and conditioning. So let's have a look at the Sever's disease condition. So yeah, it is. There would be the calcaneus and of course the growth plate. You can see there's a gap in between. It's not ossified fully, so it's very easy for the Achilles tendon to actually pull this growth plate right off. The growth plate, but the actual bone itself, because it's not ossified yet. It's easy to dislodge. Okay, so what happens there is it's due to excessive plyometric type activities, and we've already done what would be the baseline assessment for plyometrics and what support, strength and conditioning training should a gymnast be doing. So you would have to know a bit about gymnastics and the forces that are applied throughout the body, and you would need to know what level of gymnastics she is on, and you need to know her physical activity regime throughout the week to be able to adequately explain to her father why his daughter has received or got this condition. You would then refer to a physiotherapist, because when we are in phase 1 rehab, that is where the inflammation is there and you need to get rid of that inflammation, and then once the physio is completed the rehabilitative process of phase 1, they would come back to the biokineticist who would give them the correct strength and conditioning activities in conjunction with the coach that they are working with. Okay, so have a look at that, and if you have any questions, don't hesitate to ask me. Okay, you have been invited to present at a school workshop on injury prevention. So those of you who are working with children at the moment or adolescents, and you might be thinking, how am I supposed to sell this concept to parents? How do I even get started with implementing all this adolescent assessment? How do I go about doing this? This is one example In your parent evening discussion groups, if you are not confident enough to do it yet, then what you could do is you can either ask myself, or you can ask Mark Kramer, or you can ask Ryan Raffin, depending on what specific focus area you have, to come and present to the school and to discuss these areas. Of course, I would check or double check what the specialists that you are inviting will discuss, so that they cover all the bases of what your actual goal is for that lesson plan. And we've done this before. We've gone into swimming clubs and we've discussed the benefits. We've also gone to workshops to discuss this with coaches, and we've also gone to conferences where I personally have discussed these specific factors with up to 300 swimming coaches. And unfortunately, yes, you are there to coach, and each person has their specific role they need to play. So you would need to put in a management structure, create a PowerPoint presentation, bring in people on board, work with a group of individuals, and not only will this improve your professionalism, but it will also improve your networking ability and your referral ability. Okay, so obviously prevention is better than needing to actually go through the rehab process. So pre-season physical exam, again, I've already told you this. You might be thinking, yeah, but Sam, I work with athletes that don't have money for all of this extra stuff. Well, now just last week I was chatting to an individual who hosted an events fundraising evening, and the coach that did the fundraising managed to raise 100,000 rand in sponsorship from parents, and also another, I think it was 70,000 rand at the bar and from the food. So it is not impossible to build the funding that you need for your pre-season physical exam at the biokineticist. So yeah, go for that. Proper coaching, make sure that you're going for your yearly continued professional development training courses, or if you are in charge of youth athletes, or you are the sport manager at a school, or the biokineticist working with a coach, make sure that if there are any programs that are running for continued professional development, that you are joining them. And basically the coaches now that are doing this workshop, or I can't say workshop, this lecture session with me, here is your continued professional development, here is the information you need, so make sure that you use this information. Okay, adequate hydration. Do you have adequate water breaks for your youth athletes, and have you trained them to look at what the color of their urine is? I know it seems like a sensitive topic to go through, but if you handle it in a professional manner, and you give them, hand out a document in class, and you ask them to just go tick off every day what the color of their urine is, then you can quickly see whether your youth athletes are becoming dehydrated. Okay, proper officiating. Obviously you must get qualified people to do that, because children can get some serious damage from that due to officiating that is done incorrectly. Proper equipment and training surfaces with Dr. or Prof. Walter. You guys have done this already, where you go into schools or you go into other areas and you do a risk assessment. So you have the skill, make sure you use the skill. And if you have forgotten the skill, then you go and you read up on it again and you refresh your memory, because every year that goes by, once you leave the center and once you go and work in the real world, you will need to continuously be reading and updating your knowledge. Okay, and then medical aid. Make sure if you've ever been to Grey High School or other school events, there is always a medic on board, and someone who has at least a level 3 first aid certificate, so that if children have concussions or if children are badly injured, that is children or adolescents, you can take care of them. Okay, and yeah, I've said again, I would add to all of these, as you've read, is that the coach, the bio, the physio, the sports scientist and sports psychologist should work together. Set up your network, and you can do it slowly. You don't have to start with everyone immediately, and work your way up, and you will just improve your professionalism altogether. Unfortunately, parents, schools and so forth don't budget for this. Again, if you are a savvy and proactive coach, or a biokineticist trying to promote your profession, or a sports scientist trying to improve your athlete's movement ability in sports, you can host a fundraising evening and also educate. Education is key in your newsletters. Prevention is to start early. Again, if you look at the Itzvan Bailey document I sent you, you start from the age of 6 with already age-appropriate activities for monitoring your burnout, but also for gymnastics, body weight activities, strength training. We're going to be doing this now in our next module together. In terms of, well, what do you do with a 6-year-old when you train them? What do you do with a 7-year-old? And why is it so important to do this before peak out velocity and before your adolescent phase? Coaches should be well trained. Okay, I've already said that. And yeah. So in your document, you would have read also that the 3 E's are important. Educational and behavioral interventions. Again, our coaches or those working with youth athletes, set up a PowerPoint presentation, ask them to fill out a questionnaire, give them some feedback on it, say, well done, I'm very proud of you for meeting your objectives this week, well done for wearing your compression socks, keep on with the foam rolling, well, I'm proud of you guys. And just have a read through that. Environmental interventions, ensure that the terrain is suitable for play, that there are qualified staff members, that children are given age-appropriate games, and so forth. So have a look at your environment, and then legislation, stick to the rules and regulations of the game, and also especially for overhand throws or throwing, bowling and cricket, stick to the rules and regulations of how many bowling activities you should do, especially for injury profiles in children. And then Garth, I think he's mentioned this quite a few times in class. Isn't it Garth? Grant has mentioned this quite a few times in class, and it's important to take into consideration what the athlete wants, because if you are just ignoring the fact that this is a person and you're just thinking of them as an adolescent that's listening to what you say, you are going to set yourself up for problems. If we all know how adolescents can be, and which is normal because it's part of your growth and development, and being an individual and taking control of your own life and not listening to your parents, not listening to authority or authoritative individuals, you need to make sure you take the individual's thoughts into consideration. Teach them psychological coping skills. Those of you with Dr. Slowgrove and what you've learned there, perhaps not as practically applied with working with an actual set of youth adolescents, but nonetheless you do have some of the information needed, and you can read up more on that. But most importantly, you can refer. And teach proper warm-ups and stretching. And we've now just done a dynamic warm-up session together in class where we did mobilization. And I will give you a YouTube clip video on that for proper plyometric and mobilization activities, and then your flexibility stretching afterwards. Okay, so we're now reaching the 30-minute mark, but I'm going to continue so that we can finish off the main injuries. So yeah, you have a parent evening and you want to discuss Sever's disease, or you want to discuss all the injuries that can happen because they are overtraining. Let's quickly go through those again. So there's Sever's disease. Mainly for children, it's the fact that your growth plates are not yet ossified, so it's easy for the bone to pull off. Ostrich-Schlatter, again, your tibial tubercle, and that starts to actually pull off of the tibia itself because of the excessive pull of the patella tendon by the quadricep. So maybe here's an example. There the bone is not ossified yet, so it's easy for that to actually pull off. Very painful condition. The same goes for little league elbow and on your epicondyles, and this can cause the bone, which is not yet ossified, to actually pull off. Let's have a look here. There's examples. Ossification sites. There's the muscle that would be attached, and it would actually pull that bone off, causing it to be very painful. Those of you who've been doing biomechanics with Mark, you should by now know that you've learned about the forces that move through the body, and with these excessive forces and with also poor biomechanics and or excessive loading, it can cause problems. Okay, You should know where to palpate this condition. And then of course we'll look at the recommendations for training now. Okay, patellofemoral tracking syndrome. Some of us in class may have this. I know I've got it, and it's got to do with quite a few factors moving from the lower leg up that can cause medial deviation, lateral deviation, tracking problems of the patella. And the same can happen with your children, your youth athletes, and it's important to put in place prevention strategies. Okay, this one, slipped capital femoral disc. And basically what happens here is that this is where the growth plate is, and because the child is quite heavy, and normally happening in overweight or obese children, the actual disc or the head of the femur actually slips right off and can cause necrosis, damage of the nerve systems in that area, and of course problems with ambulation later in life. So, and also even hip replacements. Not something you want to be seeing in young children, so if child is presenting with hip pain, make sure that you send them off for that. Let's see here, our next one, Salter-Harris type 1 and 2 fractures, and this is with your medial or your malleolus laterally, which fractures and then pulls off of the bone. So maybe here is an example of how it would pull off. So the person would present with lateral ankle pain. Okay, your syndesmotic sprain, which can become a fracture. The actual mechanics of this being excessive loading on the lower limb, and then damage or forces happening in the fibula and tibia distally, causing actual fractures. Very painful, and of course requiring intensive rehab. Okay, let's have a look at Mason's Mason-Neuve fractures. I'm not sure if I'm saying that correctly. That's how I say it, Mason-Neuve fractures. But your tibia and your fibula actually starts to fracture and get damaged, and you will see that the person will present with a lateral pain on the outside of the lower limb. So something to consider and send for x-rays. Okay, anterior cruciate ligament sprain, especially in your females. Remember, we discussed this already. Females have a larger Q angle. So with a larger Q angle, meaning that the hips or the pelvis is wider and the knees deviate more medially, it can cause excessive rotation, and of course your ACL causes stabilization when it comes to anterior translation of your lower limb or your knee, and also when it is causing or preventing rotation in the lower limb. So here you can see your anterior cruciate ligament, and of course you don't want that to be tearing off anytime soon. So those of you who are interested, you must see the latest research on how to better rehab this anterior cruciate ligament, as opposed to using a hamstring tendon or the patella tendon or piece of the patella tendon. It is more advanced than that. Okay, so let's quickly have a look. Sever's disease, you would have the person coming to you. They would say they're experiencing pain on the posterior aspect of the heel. They must stop the activity that's causing traction force. Sent to physiotherapist for phase 1 rehab. Sent to biokineticist for phase 2 to 4 rehab. Bio will do overview of strengths and weaknesses and update training program in alliance with coaches' needs. But in brief, remove from activity, rest. You would add a heel lift to decrease dorsiflexion, foam roll and stretch where needed. Active rest is appropriate. Again, you'll see a lot of doctors refer children to say, take 6 weeks off, but this is not necessary. Work in conjunction with the doctor and biokineticist and physiotherapist, because just because your ankle is sore because of Sever's disease doesn't mean you cannot work your core, maintain your cardiovascular system, maintain your upper body strength, do other activities, stability activities for your lower body, and so forth. So please make sure your rehab process is correct. Do not take a full 6 weeks off work with the professionals and make sure that the person gets rehabbed. If you take 6 weeks off, every week you don't do activity, you can lose up to 10% of your muscle strength, your cardiovascular system deteriorates, your flexibility deteriorates, and now after 6 weeks you want to come back, you're going to be totally starting from scratch. Ossification, again, repeat points 1 to 3, physio, biokineticist, and making sure that you rehabilitate that person properly. So stop activity first, send to physio, send to bio, and then implement the specific rehab processes. Okay, so you can have a read through that. What's nice with the foam rolling is that it releases the quads somewhat, or the massaging, where that releases the quads and takes less traction off of the patella tendon / ligament. Okay. Also strapping, but the physio would do that. So you can have a brief read through all of my information. And also note, I think it's important there that some people are allergic to anti-inflammatories, so you cannot prescribe anti-inflammatories. Let the doctor prescribe anti-inflammatories. Little league elbow, again, take the person out of the activity that's causing the traction force, send to physio, and then send to bio. I want you to make sure you remember this. Aim for less than 200 pitches per week as an individual working with youth athletes. Okay, remember, just take a break in between the sessions as we go along. I know we are now on the 21-minute mark, but I want to finish the section so that we don't have to make separate videos. So have a brief look, take a break as you feel you need to, and write down any questions you may have. Remember to align this with your work that you have already done as well. Patella femoral tracking syndrome. Many of us may even have these tracking syndromes. I've already said. Repeat points 1 to 3, and then remember the intervention for that can be quite intensive, referring a person to getting shoe orthotics, knee sleeves, and so forth. Okay. Slip capital femoral disc. This is a very dangerous situation and needs immediate medical care. So if someone presents with those symptoms, make sure you send them in the correct direction. Again, any type of fracture is going to need a doctor. And when I say fractures in terms of taking time off, remember there's different ways to rehab. So you can do water-based rehabilitation, working with a physiotherapist and a biokineticist. The person does not have to take so much time off and completely deteriorate during that time period. That is why these professionals are here, to help the person through that. Okay, I think that's pretty much everything that you need to know for injuries in athletes. And let's just get back there. Injuries in youth. What are the most common injuries in youth, and the basic guidelines for interventions for at least a squat and a lunge. I'm not talking about push-ups. I'm not talking about rotatory stability. We're not going to go into that. That you'll do next year. But for those who want more information, again, let me know, and I don't mind referring you to the guidelines and where you can read up. Of course, reading up and your own practical experience and really internalizing the learning process is up to you. Anyways, if you have any questions, please do not hesitate to ask me, and I will facilitate you as best possible. Otherwise, have a listen and take notes and let me know if you have any questions.